Good evening, everyone. Welcome to today's CellTalk presentation. The presenter for today is Dr. Bharati. Dr. Bharati is a clinical content ambassador in Renix Life Sciences. Her areas of specialization include relief of immediate tooth pain. Due to her keen interest in the research field, she worked as a freelance writer and also she is associated with various research projects at NTR University of Health Sciences. She completed her MDS from Krishnadevaraya Dental College and Hospital, Bangalore in the year 2018 and her BDS from Government Dental College and Hospital, Vijayawada in 2013. She also did her intermediate schooling at Ratnam Residential School and College, Nellore. Apart from her post-graduation, she did her oral implantology and BLS courses. She also currently has 4 publications and 2 under our peer review. While she strives to work hard in this fast-paced and highly competitive environment without compromising on productivity, and at the same time, she would like to explore new skills and technologies in this research field to update her knowledge and improve her efficiency. So with this, with her introduction, we'll start with the presentation. The topic for today's presentation is the efficacy and safety of albumin-bound paclitaxel plus carboplatin as neoadjuvant therapy for potentially resectable lung squamous cell carcinoma, a real-world retrospective cohort study. The original author are Jiang et al. I now welcome Dr. Bharti for presentation, please.
Yeah, thank you, Devaki, for your nice intro. Yeah, good evening, one and all. Welcome to our CellTalk presentation. So, as described by Devaki, today I'm presenting my CellTalk webinar on the topic that is the efficacy and safety of albumin-bound paclitaxel plus carboplatin, a combination of chemotherapy as neoadjuvant therapy for potentially resectable lung squamous cell carcinoma. So it was the topic was selected on the basis of lung cancer, and it was taken from the journal named Translational Lung Cancer Research with an impact factor of 4, and it was published in the year 2022. So this research has an impact on what is the success rate of neoadjuvant therapy in lung cancer, and are there to make the patients from potentially resectable to resectable patients, are there any additional treatment options in patients for lung cancer? So without further delay, going to the topic. So lung cancer, according to the World Health Organization, it is one of the leading causes of the cancer-related deaths that are occurring. So the most common forms of treatment for lung cancer or any cancer includes the surgery, chemotherapy, and radiotherapy. So among the lung cancers, the most common type is non-small cell lung cancer. It contributes to around 85% of total cases of lung cancer. And again, in this non-small cell lung cancer variant, the most frequent subtype that is reported is squamous cell variant of squamous cell carcinoma of the lung. So this NSCLC, that is the non-small cell lung cancer, it can be divided into stages that are graded from 1 to 4 based on the spread of the disease into the adjacent lymph nodes and to the distant organs. So our topic of interest today is stage 3 lung cancer. That is, any tumors that are having the size between 4 to 5 centimeters can go under stage 3, and they are further divided into stage 3A and stage 3B based on their invasion into the adjacent lymph nodes and organs. So these stage 3 non-small cell lung cancers are quite diverse, and they frequently require regular monitoring and individualized care. So although surgery is the mainstay of the treatment for these stage 3 cancers, it is not the only standard sole treatment. Why? Because as the distant metastasis into adjacent lymph nodes and distant organ takes place, there are high chances of recurrence. So surgery is always considered in the multimodal disciplinary treatment, and it is given along with other forms of treatment. So one such treatment is neoadjuvant therapy, which will extend the survival of these lung cancer patients. So what is neoadjuvant therapy? In this therapy, neo means it's a new, adjuvant means it is an addition. So in this therapy, either chemotherapy or radiotherapy will be administered to the patient before proceeding to the surgery. And this neoadjuvant therapy can sometimes has the ability to modify these patients who are under potential resection to completely resectable patients. Potential resection is nothing but they have a doubtful chance of prognosis after resection. That is, if the tumor is extended into the lymph nodes and distant organs, even after resection, the patient might not get complete chances of recovery. So this neoadjuvant therapy, if we administer before surgery, these can modify the patients from potentially treatable patients to completely treatable patients. So the neoadjuvant therapy, according to the literature, what is the commonly used one for the stage 3 lung cancer? That is the albumin. It's a combination of two chemotherapeutic drugs. That is albumin-bound paclitaxel. So paclitaxel is a commonly chemotherapeutic agent which is used for a variety of cancers. So to overcome its properties like disadvantages like solubility, it is combined with albumin, and carboplatin is other chemotherapeutic drug which is also used for variety of solid tumors. So both these drugs are combined and it is given as neoadjuvant therapy before surgery, which demonstrated favorable effect for resectable lung squamous cell carcinomas. But however, this drug effectiveness on the potentially resectable lung squamous cell carcinoma with grade 3A and grade B has not been extensively studied in the literature. So what is the role of this NET? That is the combination of this paclitaxel and carboplatin in potentially resectable lung cancer. It still remains a question. So objective of this current study is, in this, a retrospective analysis was conducted to assess the effectiveness and safety of this NAP, that is the neoadjuvant albumin-bound paclitaxel and carboplatin in patients with locally advanced but they are potentially resectable lung squamous cell carcinoma. So they have done a retrospective analysis. They have gone back to the years between December 2017 and 2019, and they have taken patients from the Human Cancer Hospital who are diagnosed with lung squamous cell carcinoma. So the inclusion criteria were patient should be below 18 years of age, and the patient should be potentially resectable. So how do you consider them as potentially resectable? So these patients should have either stage 3 or stage 3AB lung cancer. That is, the involvement will be more than into mediastinal lymph nodes, and the tumor masses will be very large, and they will be infiltrated into all the vital organs, which is very difficult to resect. And preoperatively, like before proceeding for surgery, they should have taken at least 2 cycles of this albumin-bound paclitaxel plus carboplatin as a preoperative treatment. So after that, they have taken these patients into consideration and they have started the treatment. So they have taken a 21-day cycle. Patients were given neoadjuvant albumin-bound paclitaxel in a dosage of 100 milligrams on days 1, 8, and 15, and carboplatin in a dosage of 6 milligrams of the day 1. So then tumor nodal and staging analysis was done according to the lung cancer stage classification, that is grade 1 to 4. So within the 21 days of these 2 NAT cycles, they have evaluated these transforming tumors. So they evaluated them based on the criteria, that is RECIST, response evaluation criteria of the solid tumors. So they have designated certain grades, and that is what is complete response, what is partial response, what is stable disease, what is progressive disease according to this criteria. And they have taken what are all the adverse effects that were reported with the usage of these drugs. So these adverse effects were recorded according to the CAT-K criteria, that is the common terminology criteria for the adverse effects. So then they have taken the total percentage of patients who have transferred from potentially resectable to resectable. So this was used to calculate the surgery conversion rate. And they have also taken the patients who had given a complete response or partial response. And this was used to calculate the overall response rate, that is ORR, and disease control rates, that is D3R. So next, then they proceeded for the surgery. So following the surgery, whatever the tumor that is left, it was sampled using 1 slice per centimeter, and they examined that under the light microscope by 2 histopathologists. So this examination was done to ascertain the extent of the treatment. So how much the treatment is successful and what is the overall impact of the treatment. That is, any necrosis has taken place, any fibrosis occurs, and any inflammation is seen. Then the major pathological response, that is MPR, was defined. So how they calculated is, major pathological response is calculated after surgery if they have only less than 10% residual viable tumor. Whereas they calculated the pathological complete response This they calculated based on absence of any viable tumor cells. That is, the tumor is no longer in spreading stage. So they have taken all these baseline characteristics and statistical analysis was done, and comparisons of the pathological response subgroups was done. So using the software, they have done the statistical analysis. So from December 2017 to December 2019, overall 486 patients with stage 3 lung squamous carcinoma were detected from that hospital. In that 486 patients, they have excluded 437. Why? Because 305 patients were considered as unresectable. That is, they cannot proceed for surgery due to the vast involvement in the vital organs. And 132 patients, they were assessed as completely resectable. That is, they are not in a suspicion of potentially resectable. They can happily undergo surgery, and their chances of survival rates are more high. So that remaining 486 minus 437, 49 patients were considered eligible for the study. So with potential resection capacity, so they were treated with this neoadjuvant paclitaxel and carboplatin. In that 49 patients, 16 patients were excluded. Why? Because the 16 patients initially, along with this chemotherapy, they have also taken radiotherapy. And one patient, as the disease is progressing much, he has changed his medication from paclitaxel to docetaxel. And 4 patients, they have administered systemic chemotherapy, that is the combination of drugs. So excluding the 16 patients, 33 patients attained the surgery standards that are required for this study by the end of December 31, 2019. So among these 33 patients, 2 were excluded. There is no proper reason. The patients only refused to undergo for surgery due to their personal problems. So 33 minus 2, total only 31 patients are ready to undergo surgery. From these patients, we should calculate the surgical conversion rate, complete response rate, pathological response, and downstaging of the tumor. So among 49 patients, 33 patients recorded a partial response, and that is the partial response is nothing but reduction of the tumor in more than 30%, but no patient received the complete response. That is, after using this therapy, in none of the patients showed complete disappearance of all the tumors. These are the patient's baseline characteristics that I have taken. So 49 patients are eligible for surgery. In the median age of the patients ranges between 31 to 75 years. Among the 49 patients, 42 were male and 7 were female. 40 were smokers and 9 were non-smokers. And ECOG status is taken. ECOG status is nothing but it was the criteria given to check the disability of the patient, that is Eastern Cooperative Oncology of Group. So ECOG grade 0 is seen in 22 patients and grade 1 is seen in 27 patients. So along with lung cancer, any comorbidities were checked. So among 49 patients, 17 patients have the comorbidities. In the 3 patients has COPD, that is chronic obstructive pulmonary disease. 2 patients has diabetes. Hypertension is seen in 3 patients, and remaining unknown comorbidities are seen in 9 patients, and no comorbidities are seen. So next, stage 3A is seen in 27 patients and stage 3B is seen in 22 patients. So stage 3A is nothing but tumor will be present between 3 to 5 centimeters in size, and the tumor will extend into the adjacent lymph nodes. Whereas in 3B, tumor will be of the same size, but the tumor will extend along with the adjacent to the opposite lymph nodes also. And baseline criteria, that is N0, N1, and N2. Tumor staging, N0 is seen in 6 patients, N1 is seen in 8 patients, and N2 is seen in 35 patients. So only 31 patients. So after excluding the 2 patients who doesn't want surgery, only 31 patients were ready for the surgical outcomes. So these 31 patients are taken into consideration. So for these 31 patients, 21 patients underwent thoracectomy, whereas 10 patients underwent video-assisted thoracoscopic surgery. Again, in 31 patients, 23 patients underwent lobectomy and 8 patients underwent pneumonectomy. And in these patients, 30 patients were undergone R0 resection. So R0 resection is nothing but removing the surgical tumor along with the microscopic margin. Whereas R1 resection, the microscopic margin will be left intact and only the tumor will be removed macroscopically. So next, down TNM staging, that is decreasing the staging of the tumor. It is seen in only 21 patients and it is not seen in 10 patients. So among these 21 patients, from N2 to N0, it is seen in 8 patients. From N2 to tumor reduced to N1 staging is seen in 9 patients. From N1 to tumor reduced to N0 stage is seen in 1 patient. So after the surgery, any patient developed the complications. So none of the 27 patients doesn't reported any complications, whereas 4 patients reported some surgical complications like leukopenia and neutropenia. So in the 31 patients who underwent surgery, so 11 patients, that is 35%, had an MPR, that is, they have only less than 10% residual tumor after this neoadjuvant therapy. And among these 11 patients, 5 patients achieved a pathological complete response. So the overall response rate for these patients who attained this MPR was around 82%. So along with that, the radiographic objective response and the MPR of the patients who underwent resection, it didn't correlate it, that it is not statistically significant. And neither gender, histology type, stage of the cancer, and past smoking history, that doesn't have any statistically significant effect on this achieving this pathological complete response. So what are the treatment-related adverse effects that we got? So diarrhea is seen in 1 patient and liver dysfunction is seen in 9 patients. Nausea and vomiting, fatigue are seen in 2 patients each. Leukopenia is seen in 2 patients and anemia is seen in 4 patients. Sinus tachycardia is seen in 2 patients. So coming to the discussion, so with the localized or loco-regional non-squamous cell carcinoma, lung carcinoma, so neoadjuvant chemotherapy has demonstrated a considerable survival advantage. So compared to only surgery alone, along with before proceeding for surgery, if we give this neoadjuvant chemotherapy, it has definitely has a considerable survival advantage. But however, despite of the survival advantage, a number of clinical trials have demonstrated that these 2 drugs, when combined, they have reported a certain level of toxicity, and the conventional combination will result in chemotherapeutic sensitivity. So this lung cancer patients frequently employ this NAP, that is the neoadjuvant albumin-bound paclitaxel, which has already demonstrated a stronger anti-tumor effectiveness. So, but in LSCC patients, the pathological response when using as a chemotherapeutic agent, it has already determined strong anti-tumor effectiveness. But what if it is applied as a neoadjuvant agent has not been well studied. But the results of this study, which used this as NAT therapy, correlated with the earlier studies in terms of the major pathological response and pathological complete response for the stage 3 cancer patients. So we can consider that neoadjuvant chemotherapy with controllable adverse effects should help these patients who have the possibility, that is the potentially resectable tumor. And after that, if we perform the surgery, it will offer a viable treatment for these patients. And among with this NAT, that is the neoadjuvant therapy, recently immunotherapy has gone into various advancements, and it has also given some valid inputs into the treatment for non-squamous cell carcinoma. So neoadjuvant immune checkpoint inhibitor monotherapy has also been to observe overall improved survival in around the rates of 19 to 45%. So what are the drawbacks in this study? So as we are taking the retrospective analysis, so we have started with some 486 patients and ended up in around 43 or 31 patients. So unavoidable bias will occur due to this retrospective analysis. And so multivariable analysis to account for the confounders was not performed because the sample size is very restricted. And patients are taken only from 1 hospital. So this study's findings and results are not applicable to all geographic areas. And they have taken only short-term efficacy endpoints like surgical conversion rate, overall response rate, and pathological response. So survival benefit cannot be completely determined with the short-term efficacy endpoints. So to conclude, after receiving this albumin-bound paclitaxel and carboplatin therapy, stage 3 and stage 3A and 3B possibly resectable lung cancers had a significant surgical conversion rate of 67% and major pathological response of 35%. So this therapy can be effectively administered as neoadjuvant chemotherapy for the patients who are considered as potentially resectable. So the impact of this research is It helps in determining whether to consider this NAT therapy as a neoadjuvant option for potentially resectable patients, and it determines the anti-tumor effectiveness of this NAPC and whether we can use this along with immunotherapy. Thank you for your patient listening. You can find me at bharti@renex.com.
We have questions from the audience. There is a question from Vijay. How is albumin linking helpful?
Yeah, because paclitaxel and docetaxel, they belong to the taxane group. They have the disadvantage of solubility. So to overcome this, we are linking it to a protein compound called albumin, which reduces its solubility and increases its effectiveness.
Okay. And also there is a question like why upper age limit was set to 18 years?
Why? Because patients belonging to the group of 18 years, if they have the status from potentially resectable to resectable, that we can easily monitor because they doesn't have any like age existing diseases like diabetes and hypertension. They will be comparatively healthy when compared to the older people. That's what I felt. It's not given in this.
Okay.
So we can easily monitor the surgical conversion rate in them.
Okay. I hope Vijay, you have got your answer. There is question from Nupur. How the result depend on the types of chemo drugs?
Because in this study, we have combined two drugs, that is the paclitaxel and carboplatin. Their combined adverse effects might influence the surgical conversion rate or the major pathological response.
Okay. Any questions from the audience? I believe there is no further questions. Thank you, Bharati, for your presentation. For next week, we have the presenter, Isha Shah, and her presentation topic is on leveraging social media to increase lung cancer screening awareness, knowledge, and uptake among high-risk population, study protocol of design and methods of a community-based randomized control trial. The author is Bava et al. The presentation will be on 9th August 2023. Thank you all